All right. Well, we're going to move from the molecular to the macromolecular. How do I make this one? Start from begin. I don't know. How do I get this to make us? It's usually at the bottom. Oh, here it is. I think I see it now. Just got to get the mouse there. Huh. I think I see it. There it is. Just got to get the mouse there. Ah, excellent.
And this is your pointer right
Thank you. Yeah. No, that didn't work. Okay. Where's the pointer?
Is the center one?
Oh, okay. Thank you. Again, it's a pleasure to be at this meeting. I try to come at least once a year to meet my colleagues and to describe what I do to you and to learn from you. So, as you heard from my introduction, my area of interest as a heart surgeon is within the area of both chronic and acute heart failure. In the past, I've talked about long-term mechanical support devices that can be used either as a bridge to heart transplantation or as a permanent implant technology for people who are not eligible. This year, I'd like to talk to you, at least today anyway, about the evolution of ECMO, extracorporeal membrane oxygenation. It's a relatively old concept and an old technology that originated more than 40 years ago and fell out of favor for a long time and has more recently had a resurgence in application for reasons that I'll describe to you. And I've taken a strong interest in this in my career and want to share with you this little journey today about ECMO in the adult. I don't want to spend this lecture talking about neonates and pediatrics, which is where ECMO is utilized quite a bit. I want to talk to you about adults and some of the strengths and weaknesses of the technology, and also bridge into my lecture tomorrow, if you're here, about how to make it even better by using hybrid technologies with ECMO. Okay. So it's interesting to understand the beginning of ECMO because it really starts with the actual invention of the heart-lung machine, which began in the 1940s. Dr. John Gibbon Jr., as a house officer, was very frustrated by a patient who died of a massive pulmonary embolus, and in his brain he thought if he could bypass the circulation with a machine, maybe that patient would have survived. And so he spent a long time trying to develop a heart-lung machine, a pump oxygenator, and together with his wife, who was probably the earliest perfusionist in the world, they did develop this machine, and you could see it's gigantic. It's a massive unit that worked for this patient here who had the first successful use of the heart-lung machine to repair an ASD in May the 6th. Remember May the 6th, it's going to come back. In 1953, actually, where I'm professor of surgery at Thomas Jefferson University Hospital. So it has a professional and personal place in my life because it was done at the institution where I work. And it was 26 minutes on this machine, and the patient actually survived. And it was heralded as like the greatest invention ever in medical surgical community. Unfortunately, the next half a dozen patients he tried it on, they all died. He became very disenchanted and said, "This machine doesn't work, it kills people, and I never want to use it again." Thankfully, others did not adopt that idea of discontinuing the heart-lung machine, but rather used it to perfect it, and it's commonly used now in more than 500,000 cases in the U.S. alone. But what it did do, and what we talk about a lot, is spin-off. So maybe the heart-lung machine, at least at that time, may have had a lot of complications, but a lot of spin-off technologies developed as a consequence of it. And Dr. DeBakey, who's pictured there, and here in the state of Texas, not San Antonio, but Houston, he took that concept to another level, and he developed in his lab and in clinical practice the LVAD and the total artificial heart. I won't go into this legendary story of how he and Dr. Cooley fought over the first use of the total artificial heart, but Suffice it to say, DeBakey developed it and Cooley put it in without his permission, and they didn't speak to each other for about 40 years. But the ECMO that is what I'm talking about today is a spin-off of the original heart-lung machine, and you could see on the bottom picture just how busy the technology gets when you want to use it for acute cardiorespiratory failure outside of the operating room in its formal use as a heart-lung machine. And it took a couple of decades before the first clinical use in an adult successfully supporting a patient outside the operating room for a condition that was a result of a motorcycle accident in a young man who developed ARDS. And Don Hill, who I met early in my career, was the first guy to report its successful use back in 1971 on May the 6th. Very important day. So the patient survived, and then once again, this heralded excitement over this technology for use in acute cardiorespiratory failure. Now, if this patient presented all over again, it might have been veno-venous ECMO, but this was veno-arterial ECMO for 75 hours with a membrane oxygenator that is very, very scary to look at. This gigantic cylindrical unit here is the membrane oxygenator, quite formidable. Needless to say, though, Dr. Hill continued with the technology along with the godfather of ECMO, Dr. Bob Bartlett. And Dr. Bartlett's career included the neonates and the pediatrics. He had a lot of training over many, many reputable institutions. But the most famous story is about this little baby who, in that picture, is a young woman, nicknamed Esperanza, which in Spanish means hope. And she was nicknamed that because her mother was Mexican and was going into labor and wanted her baby to be born in the United States. She crossed the border emergently, broke her water, and delivered the baby in a hospital in the United States, but the baby aspirated meconium and was going to die. And Dr. Bartlett, who had been doing a lot of research on ECMO prior to this, decided to give it a try in this little baby and became the first successful neonatal use of ECMO in 1975. The little baby was on it for 3 days, and the cannulation was typically in neonates the right internal jugular vein to drain the blood and perfuse it back into the right internal carotid artery. Dr. Bartlett, by the way, is still alive and still a very, very important person for ECMO as the godfather of the Society for ECMO, which I'll talk about later. Well, actually, I'll talk about it now. So in 1989, moving forward, the ECMO Society was formed, and the name is ELSO, E-L-S-O, Extracorporeal Life Support Organization. And it had only a few programs representing it, most notably University of Michigan. And that's where Dr. Bartlett ended up and continues to be on staff there. They came together in 1989 in Ann Arbor in October and presented 5 years' worth of data. And this is extremely important, as we all understand the data collection, the data interpretation. And since 1989, this society continues to publish its data twice a year and continues to present at national meetings and other venues the data related to 3 areas of ECMO, neonatal, pediatric, and adult, and we'll talk about adult. Okay, so as you heard before and as you saw before, it is an offshoot of the heart-lung machine. So it consists of a pump, and it consists of an oxygenator, now much smaller than the one I showed you before. But it has other things too. It has a heater water bath. As you can appreciate, when blood is taken out of the body, and it's a couple of liters of blood that's circulating through plastic tubing, patients will become hypothermic very, very quickly. And sometimes we intentionally do that. If a patient arrested and you want to put them on the hypothermic protocols, you just turn off the heater cooler and let them cool down by virtue of the blood just being outside the body. But if you want to keep them normothermic, then you can turn the heater cooler on, and it's just a warm water exposed to the plastic where the blood is, and it warms up the blood. You have all kinds of monitors, SVO2 monitors, and many, many other monitors, anticoagulation test devices, and so forth. And then the pump and the oxygenator varies depending upon what unit you're using. But it's much more streamlined than it used to be, and at the end of this lecture, I'm going to show you the state-of-the-art ECMO circuit, which now you can carry literally with your hand. It's about this big, and it's got everything that you see here in a very simple unit. I'm going to fast forward because we only have 30 minutes to talk about this, but what really brought ECMO onto everybody's radar as something that will soon become, and I believe to be, the standard of care, were two events that occurred in year 2009. One was this trial that got published and represented data prior to 2009 called the Caesar trial. This was extremely important landmark paper that looked at patients who developed ARDS of almost any cause and comparing optimal ventilator management to veno-venous ECMO. And it was clear after the results were obtained that veno-venous ECMO for the most severe forms of ARDS had a better outcome than maximal ventilator management. And there's some data here that you can look at, but it was important to appreciate the inclusion criteria, which I'll go over, and the exclusion criteria. I'm not going to go into all the statistics and all the other stuff that go with this. I want to highlight for you some concepts. The most important thing is that, at least to the best of our abilities, and we're not always perfect here, to the best of our abilities, the condition that we're dealing with is potentially reversible. It's not always easy to predict, but if you had somebody with, at one point in time, fairly recently to whatever occurred, relatively normal lung function, something occurred, and then you institute the therapy rapidly, you have at least some idea that it's going to possibly reverse back to a normal lung function or a near normal lung function, as opposed to somebody who does not start out with normal lung function but has severe lung dysfunction, then becomes acutely decompensated. More likely than not, you can support them with the ECMO, but their underlying chronic lung disease will not bode for a good outcome. So that's important. And in the inclusion criteria, there were all kinds of parameters called a Murray score. I'm not going to go into the details of that, but these are ventilator parameters, blood gas parameters to allow you to help identify patients for better or worse selection criteria. Now, the important part on the exclusion criteria is the duration of the optimal ventilator management of more or less than 7 days. And the data, since this has been published, really bears merit because we have learned the hard way that if you're going to keep a patient, for example, on a ventilator at 100% oxygen with large volumes of positive end expiratory pressure, if you keep him in that condition for more than a week, you end up with significant problems of reversibility of lung function. So yes, you can sustain him on the ECMO after that time, but the reversibility diminishes the longer that patient was on those kinds of vent settings. So in our program, for example, if we are very, very uncomfortable putting someone on ECMO if they've been on 100% oxygen with 15 of PEEP for more than a week, because we know those lungs are fibrotic and they're a lot less likely to reverse. And here's some of the data on the outcomes. You can see on the red bar the ECMO survival, and on the dotted blue bar the conventional management survival, and clearly ECMO had an advantage. Here's the other thing that happened in 2009, and actually before 2009, but published in 2009, the H1N1 flu epidemic worldwide. There are tons of papers. I'm just representing one of many, many papers that talked about this flu and how people were dying of H1N1 flu. And this paper and several others talked about the advantage of putting people on ECMO in the most severe forms of the H1N1 flu. And you could see some of the results here. This was an Australian-New Zealand study on patients with this condition, and you could see the advantage of the patients who were placed on ECMO compared to those that did not. So clearly, ECMO for ARDS, for flu, and for any other respiratory condition that is potentially reversible in the most severe forms, there is an advantage to putting them on ECMO for a period of time until the condition resolves. Cardiac ECMO, I showed you the first case of that trauma patient back in 1970s, but it has not had as friendly an application as the pulmonary ECMO. But there are a few studies that talked about ECMO in cardiac conditions that are really quite profound and quite severe. Cardiogenic shock from medical causes, most notably acute MI, cardiogenic shock following open heart surgery, referred to as post-cardiotomy shock, and then you have the cardiac arrest patient. There's no randomized trials here, so we're just looking at retrospective data and talking about the fact that a lot of the patients that were put on the ECMO for those conditions would have died 100% of the time had they not been. So this was a rescue type of therapy. And in that rescue therapy mode, you're looking at anywhere from 25 to 35 and as high as 38% survival, which compared to 0% survival looks pretty good. But it's still not as good as the respiratory ECMO, which can be up to 70% survival. But be that as it may, it's a tool that is used quite commonly for these conditions. And once again, if you can use similar logic, you're not going to put somebody on ECMO who they've been coding for 2 hours and is severely acidotic and not likely to survive. Even if you were able to support them, they're going to have anoxic brain damage, they're going to have multi-organ system failure, and so forth. I'm talking about adults now, not the little kids. Little kids, you do everything. I'm talking about adults. So there's not a lot of great data, but there is some data, and as I mentioned before, the registry collects this data. So for example, here's the most recent report. There'll be another one coming out very shortly. This is July of 2015. It's an international registry, and it just keeps accumulating patients. So you can look at the categories. You could see pediatric, neonatal, and adult here. And then you could see the total number of cases, which again will continue to climb as the data gets collected. And here you could see the absolute number of survival with ECLS to be differentiated from survival to discharge. And I'm all too familiar with this, and this is where you heard before the reliability, reproducibility of data. When I was doing a lot of early work with the ventricular assist devices, people would stand up and talk about survival of 50, 70, 80% survival on these acute LVADs. And what they meant was they were able to, let's say, take the device out of the patient as a endpoint. And that wasn't really accurate, because what you really want to talk about is, did the patient actually go home alive and well? And that's where this other category comes in of survival to discharge or transfer. So you could see here, you have survived ECMO, 66 and 58, 56 and 42, 40 and 30, different numbers, because some people get off the device, but they die. So I always look at sort of the last column, because that's the one I really care about. And you could see for adult respiratory ECMO, international numbers look at 58% survival to discharge. For cardiac adult, 42% survival to discharge. And ECPR is the one where you're cardiac arrest, 30%. So those are numbers, and they're benchmarks for programs like ours and many, many others to benchmark against and to see if we can improve upon these results. And improvement on the results are going to stem from everything from what we talked about: patient selection and things we didn't talk about yet, technique, and device, and then management. Those are the three main areas that you're going to make an impact on your outcomes. So you have to select the correct patients as best you can. You have to be technically excellent, because the complications of ECMO, most notably, is bleeding. But there's other complications as well, neurologic, I'll talk about in a minute. And management. You must have a dedicated ECMO team of people who understand the technology and understand the management. It's multi-organ management. It's multifactorial. So our team was formally established in 2013, more like 2012 into 2013, actually. We've been doing ECMO, I've been doing ECMO for 25 years, but we never formulated a team. Well, we finally formulated a team, and you have directors at different levels: surgical director, medical director, clinical director, administrative director. There's a lot of directors, but there's a lot of other people who are extremely important, and these are sort of your frontline people, your nurses and your fellows and your perfusionists and so forth. So we have an ECMO team, and we have very, very strict protocols, and nobody else in the hospital manages the ECMO patients other than the ECMO team. And this is very, very important to talk about outcomes. We have many, many hospitals we service, and everything has to be standardized and uniform. So we have a standardized cart, which has all the things in it that we need, everything from gloves and gowns and tools and things like that, and all the carts are exactly the same in the 4 hospitals that we service. To the unit there, this is our little, a little unit, the pump oxygenator unit. There's the oxygenator, there's the pump, here's the unit. And the cannulas are standardized too. We have the same cannulas everywhere. So there's no guesswork in terms of what to get when an ECMO is needed. We have two resources we use, and this helps us not only for ourselves but for the staff. These 2 books are extremely valuable. There's a lot of material in there for training purposes, and then this is really a lot to do with not only the history of ECMO, but the important publications about ECMO, and this is up to the 4th edition now, so it keeps getting updated and is part of this thing called the ELSO Society, which I talked about. So these 2 books sit in our intensive care unit, they sit in the fellows room, they're in our library, and they're frequently used to understand the physiology, pathophysiology of ECMO. This is a company, and I'm not trying to promote anything here. I'm just trying to explain to you how serious we take this. This is a company that is made up of ECMO specialists. They're called ECMO Advantage. They can come around to any institution, at least in this country. I don't know if they're international, but they can go around to any program and help you design your ECMO service. Well, they came around to ours. We used a simulator. This is actually a mannequin, but is hooked up to monitors that you can do any kind of simulation: respiratory failure, cardiac failure, cardiorespiratory failure. And then we have the actual ECMO circuit. This is a real circuit that we bring to the simulator, and the staff and the fellows and everybody can learn how to put the ECMO in, which kind of ECMO to put in, and then discuss things like flows and pressures and adjust things for complications, how to deal with disruption of the circuit, how to deal with bleeding complications. Anything you could possibly simulate can be done in this simulation laboratory that we have, and this is some of our staff. And here's our little classroom with a lot of the nurses, and here's some of the fellows. And this is a 5-day course. After 5 days, you get a certificate. And by the time you're done, you really understand this extremely well. Some of the cannulation things we go over, and as I mentioned to you before, it has to be technically excellent, because without this you have bleeding and vascular complications that can create more problems than you can possibly imagine. There's 5 liters of blood flowing through these tubes, and if you don't do it right, you'll get fistulas, hematomas, retroperitoneal bleeds. If you don't connect these things with the little tie band, something can disrupt when the nurse is turning the patient. Something can come off, something can snap in this distal perfusion catheter. So it's important to understand the technical excellence that has to happen, because when it's done right, it's really quite easy. And there's an expression in the ECMO world, ECMO is 90% boredom and 10% catastrophe. It's just, that's the kind of world it is. If you do it right, it can appear to be very boring, but if something goes wrong, it can be catastrophic. Okay. So in terms of the different cannulations, for veno-venous ECMO, which is the respiratory failure, you have a couple of options, and we do most of this with fluoroscopy. We place these cannulas, one of them in the lower part of the vena cava to drain the blood out, and then the other one goes also in the inferior vena cava, but up toward the right atrium. That's one configuration. So the deoxygenated blood comes out, gets the oxygen, gets pumped up to the right atrium, and it mixes. So it's not a perfect oxygenated blood, it's going to mix. And that mixed blood will go through the tricuspid valve, right ventricle, pulmonary artery, and eventually make its way around systemically. The other configuration is the cannula in the inferior vena cava, just like this one, but you infuse through the right internal jugular vein, again, into the right atrium. It's a great configuration. It's been used for decades. But one thing that a company developed, which is brilliant, is this thing called the Avalon cannula, and it's a single cannula with two side holes. It's inserted through the neck and the jugular vein, but you could see the two side holes. It comes down, and it has one lumen that will drain the blood out, and the other one will pump it back in through the second lumen, so you have these two lumens. The second one has the oxygenated blood. This we need both fluoroscopy and echo, because you have to aim toward the tricuspid valve. It's very, very important. So if you don't, you're not going to be positioned right. You'll be ineffective. But it's one unit. It's one stick, and it's very, very good. And for programs that do things like lung transplant, for example, and they're failing, and you need something to carry them to a lung transplant. Now we don't do that, but I know people who do. They put this cannula in the neck, and they have excellent oxygenation until they get a new lung. But these patients literally are walking around with a portable pump oxygenator with this thing in their neck. And it's quite impressive, and it gets people sitting up in chairs and moving around until a new lung becomes available. And they have very small versions of the pump oxygenator for this particular indication. So our program developed a process, like all programs, where if you're thinking about ECMO, and we get an activation pager and an overhead page and things like that, and we deliberately made the pager, the numbers, to correspond to the letters. So if you're in our hospital and our health system, all you do is call the pager ECMO, ECMO, which corresponds to 3266. You might be in the operating room, the ER, the ICU, or you might be outside of any of those places, and you call this pager, and then the team assembles, and the team has the physician and the coordinator, ECMO coordinator, and then all these different other people get involved. And we benchmark ourselves to have somebody on support, once that pager goes off, 30 minutes. So we kind of used a similar concept to the cardiologists that do the acute MI, STEMIs, with door-to-balloon pump. Oh, okay. I'll finish up in 5 minutes. We kind of benchmark to 30 minutes. So we're trying to activate this process very quickly and get everybody moving along very quickly. These are all the different indications we've had for cardiac. Myocarditis is a great one because they often recover with time. All the different infections, we've done a lot of different things. The bottom line is you kind of know it when you see it. Somebody getting CPR that has a witnessed arrest, we'll put them on. Somebody who's been arrested in CPR for 2 hours, we don't. Somebody with that kind of x-ray, you don't need to be a rocket scientist to figure out their lungs don't work. Our outcomes have, since we formulated it between 2012 and 2013, overall have improved from 27% overall survival for both VA and VV to 36 to 45 to 52. Now, we're not finished with 2015 yet, but we're probably on pace to have a 60% survival. For pulmonary, we have between 70 and 75% survival so far for 2015, and about a 50% survival for cardiac, and I told you what our benchmark is. So I'm going to finish up with a very quick case. This is a young woman who presented with a cardiac arrest. She was coaching a soccer game with her kid, and she arrested from an LAD diagonal occlusion. She's only 30. I don't exactly know what the etiology of her very premature coronary, but she must have ruptured a plaque somewhere in the LAD diagonal system. But she got reperfused very, very quickly, but she was in cardiorespiratory failure. So she originally got an impella LVAD, which I'll talk about tomorrow, but she was also hypoxemic. So we switched her from the LVAD, which wasn't doing anything for the lungs, to the VA ECMO. And we were at a different hospital. We transferred her, and then she recovered in 5 days and went back to a normal life with normal cardiac function. But she needed that technology to get her over the hump. So we've come a long way in 40 years. This is representative of all the number of cases, particularly in the last 5 to 10 years, that have ECMO capability. Like I said, there's now a resurgence of number of centers and number of cases. And society has extended beyond the U.S. We now have it in Europe, we have it in Asia, and they're all part of this bigger ELSO international society. The new technology I talked about, I think this might be my last slide, has that entire unit now in something that is very, very portable and has all the bells and whistles. So it's not just a pump and an oxygenator, but it has all the monitoring, the pre-membrane, post-membrane pressures, the oxygen saturation, the flow monitors, the alarms. Everything is very easy. So now you can take somebody wherever they are by ambulance, by aircraft, by helicopter, and it's even easier to transport than a balloon pump. A lot easier. You can see how it's on the side of the stretcher. So just in conclusion, it's been around for more than 40 years. It's a valid therapy for cardiac and respiratory failure. The things that's important is patient selection, technical application, training, management, and so forth. The society has been around now since '89 and is very important for data to help make progress. And we've done a lot with the technology to help make it more applicable to all comers. Thanks a lot. It's a pleasure, and it's going to dovetail into what I talk about tomorrow, but thank you very much. Any questions?
Thank you very much, Lou. Try to stay on time. We're a little bit running late. We should go ahead and